All right. Good afternoon, everyone, and hello, 2018 scholars. My name is Maureen Fitzgerald, City Match Staff Lead. Again, on behalf of CDC's Division of Reproductive Health, HRSA's Maternal and Child Health Bureau, and City Match, welcome back for the second pre-training webinar. We'll do the housekeeping before we get rolling. As usual, our webinars begin with all your phone lines muted. To unmute, press *7. And our presenter today wants you to know that if you have a question in the moment that you really want to ask, that you would prefer that you go ahead and do that. Press *7, ask your question, and then you can press *6 to mute again. It's a little easier to have a nice interactive conversation than to type things into the chat box, although you're welcome to do that as well. The next thing you should know is that sometimes we will unmute all the phone lines for open discussion. If we do, we'll give you a heads up. This is the real world. You could be in a conference room with a bunch of other people typing, multitasking. So we'll give you a heads up. At the bottom left, as I said before, there's a chat box. You can use it to type questions to individuals. And also you can use it if you have a technical or a system issue. You can use that to alert me, Maureen, for troubleshooting. Next, don't ever put the call on hold. If you have to step out, just keep your phone muted. Or if you need to disconnect, go ahead and call back in. Hold music can drown speakers out pretty effectively when the lines are all unmuted. Last, if you're accidentally disconnected from the phone or the web, just call back in, log in, rejoin. Don't worry. Everything's recorded, and you'll each get an email with the required evaluation, the PowerPoints, and the recording later today. So that's it for housekeeping. Now please join me in welcoming Lead Project Officer for this course, Dr. Deb Rosenberg. You've all received her bio sketch in your invitations as well as your confirmations. So at this point, I'm going to turn it over to Deb to begin the webinar.
Can you hear me?
Just great.
Great. Okay. Well, hello, everybody. The first thing I have to say is I don't really think I'm the lead. Whatever Maureen just called me, I don't think I'm that. I used to be, and so this feels kind of like a coming home for me because I've been involved with this training since the beginning, which is, I believe, in either 1999 or 2000 in various iterations. And I stepped away for, I think, the last 2 years, and I'm happy to be back, particularly because I'll see you next week in my beautiful city, and I know that Maureen's going to provide you, I think, with lots of information about things to do in Chicago when we're not all immersed in the training. But just if you want to ask me any questions about that or give you recommendations for anything, I'm more than happy to do that. I'm a foodie and I'm a music addict, and there's a lot of both in this city. So when we see each other next week, we can talk about all that too. Today we're going to start out really just trying to frame what's going to happen in the course. And so we're going to do a quick tour of the classical and some more current frameworks for stats and epi analysis in our world. And this is what I hope to talk about a little bit today. So first, think about, we're going to be very focused on methodological issues for all of next week. And so to just locate those within a broader context of really what all of our jobs are about, which is doing practice-based MCH epidemiology, and do a little bit of summary of, broadly speaking, of statistical and epidemiologic frameworks, talk about general steps for good data analysis, and very briefly talk about the role of theory. And let me just say that all of these topics will be revisited, I'm sure, throughout the week. But again, as Maureen said, I like to be interrupted, so feel free if you want to. It doesn't have to even be a question. If you want to make a comment, disagree with me, agree with me, whatever, let's start the conversation now, and then we'll continue it next week. Let's talk about consequential epidemiology, and for our broad vision as who we are as epidemiologists generally and MCH epidemiologists in particular. So this is from James Marks, and it says, in 1983, giving the Wade Hampton Frost Lecture at APHA, Bill Fogg, former, did I say that right? Is it Fogg? I can't remember now. Former CDC director, coined the term consequential epidemiology. It was his conviction that public health was inherently political, inescapably political. Fogg argued that public health work occurs in a political context, and that divorced from that context, our science is stillborn, a missed opportunity. To pretend otherwise is self-delusion and a failure of vision and responsibility. So that's a pretty broad and powerful statement. And then more recently, more drilling down to our actual day-to-day work and the way we conduct ourselves as epidemiologists in our jobs. This is from Sandro Galea, who you probably know is going to be a speaker at the MCH Epi City Match Conference in September, which I hope most of you will be attending, so you'll get to hear more from him. But in any case, quote, in recent decades, our discipline's robust interest in identifying causes has come at the expense of a more rigorous engagement with the second part of our vision for ourselves, the intent for us to intervene, and this approach threatens to diminish our field's relevance. A more consequentialist approach to epidemiology clarifies our research priorities, offers a perspective on the place of novel epidemiologic approaches, and a metric to evaluate the utility of new methods, elevates the importance of global health and considerations about equity to the discipline, brings into sharp focus our engagement in implementation and translational science. So we've got the broadest framework about where we sit, even as scientists, in the world of politics and social engagement, and then a little bit more narrowly, but equally, I don't mean narrow in a pejorative sense, but just more down to what we do at our desks every day. We have Galea talking about how we function as epidemiologists. Here's something that we put together. You're going to see, and I'm sure you all at one time or another have probably seen what I call the MCH planning cycle graphic, and I'm guessing, and I'm pretty sure I'm right, you will see a general, this graphic more generally laid out when you hear Dr. Sappenfield here next week about the MCH planning cycle. This is a version of that tries to map specifically our work, the data piece of what it means to be part of the planning cycle in MCH. And in the title you can see I've called this the MCH Epidemiology effort in quotes. And that came from work that I did with my colleagues Arden Handler and Amy Herman Roloff and Joan Kennelly for the CDC on understanding what makes for good MCH epidemiology functioning in state and local health agencies. And I guess I could share that article with you. And the term MCH epidemiology effort comes out of that because it was a recognition that it's not just the particulars of doing data analysis and writing a great data report, but how do we fit in the broader context of the MCH work that is done in public health agencies. So you can follow around the circle here from plan and follow the arrow to looking at descriptive statistics, to look at contributing to setting the MCH agenda and supporting the prioritization process. So that's about the needs assessment that we're all, about to be or are working on again. And then developing analytic and evaluation plans, setting indicators, selecting indicators and deciding what targets we're going to use for performance measurement, and then the things that we're going to do, we might have to collect new data. We're going to monitor progress towards on the indicators that we selected. We may do some in-depth analysis on a few key MCH health issues as they relate to the priorities that have been chosen. And we're also going to do program evaluation. And then in the middle, and this is equally important, is our role in promoting data quality, doing systems development, data linkage, sort of challenging our agencies about collecting new data, because we all know we don't have all the data that we want. So that's part of our job too. And then also disseminating and translating that data, providing interpretation, not presenting findings, but going beyond that. And this is part of the consequentialist approach. It's not just, the present the table that shows the results that we found, but it is really helping our partners in MCH. It's not that we have to be the be-all and end-all about interpretation, but our statistical and epidemiologic expertise should really be used to inform and push the interpretation and challenge assumptions and talk about what else we need to be doing analytically, and tying that to then what else do we need to be doing in terms of public health action. So again, you're going to see a graph like this, I'm sure, and a lot next week, particularly from Dr. Sappenfield. So in our work, one thing that makes our work, I would say, difficult and almost more difficult than when I have my academic hat on sitting at UIC School of Public Health, is that we need to use epi and stats to do a whole bunch of different things and to really synthesize across all of these kinds of functions, from surveillance and monitoring through needs assessment, on and on and on, through program evaluation, to helping with policy development, to helping with advocacy, maybe doing some actual research, whether it's strictly epi research or health services research. But we have a large palette of things that we need to be bringing our expertise to, and that's why we really, and part of what this training is about, is thinking through the whole array of methods that might be useful in addressing this really wide-ranging scope of work that we have. And when we do that, we're often looking at, whether it's surveillance or monitoring, whatever we're doing, across various population groups and with different foci, with a different emphasis. Sometimes, in classic EPI, we would tend to be mostly looking at health status indicators, at health outcomes, and thinking about exposures and outcomes. But in our world, we're looking not only at those outcomes, we're looking at health services that are there to address those outcomes, and health systems that's even at the more macro level. So again, we have a really broad-ranging scope of work, and what are the tools that we're going to need to do that work well? What we really need to do all the time, but especially in this very complex context that we work in, is to be good about developing systematic analysis plans. And I say this being a person that myself often wants to dive in and sit down at the computer and grab the data and do a whole bunch of stuff. And I have learned over time that I need to really push myself, challenge myself, force myself to do the hard work of developing a plan before I actually just do that. Because, you know, if I don't do that, I'm probably not going to end up with as rich and meaningful analysis, an analysis that can really be translated in a way that is needed by my immediate stakeholders, to say nothing of the women, children, and families we serve, but for the program managers, policymakers, et cetera. It's really in everyone's interest that we develop a good analysis plan. Doing that work of having a systematic approach involves thinking a lot about how we're going to summarize data. So sometimes, in MCH actually, more than in many other fields, we are lucky. Although we don't have all the data we want, we have some very rich and large data sources. And so the key for us is to maximize those, figuring out how to organize and summarize all that data. So what methods are the best to do that? What statistics do we want to report? And so this is where we want to build our expertise in all of those stats and epi approaches, so that we have lots to choose from when we think through how we're going to develop our systematic approach. Let's talk briefly about kind of the classical way that stats and epi are talked about. So statistical methods, this is the way I often talk about it. Statistics provides the mathematical rules for estimating population averages. Remember, everything's about averages. And for formally testing hypotheses about those averages. And then epidemiology focuses those mathematical rules on the occurrence and pattern of disease in human populations. And epi really, the work of epi is to guide both study design, and I don't mean that necessarily like research design, but again, this is about creating an analysis plan. So our design and our analysis, and that then helps us decide what statistics we want to report. Classically, we kind of think about categorizing or compartmentalizing the statistical approach into two broad areas. And I call this everything about statistical analysis I think of as the sampling framework. And then within that, we have estimation, where we're just going to estimate population characteristics, or we might estimate relationships between two or more population characteristics. And in the arena of estimation, that includes not just getting point estimates, right? We're going to get an estimate for whatever indicator or combination of indicators, but we're also going to talk about using confidence intervals around those estimates. And then the second broad category is hypothesis testing, where we're going to do formal statistical tests, which, as you know, go beyond just using confidence intervals, but actually rely on probability distributions. And we're going to actually do formal testing about the estimates that we have, or the combinations and relationships between estimates that we have. The sampling framework is that everything we do in public health, even though we're always talking about population analysis, and in our world, you know, we have the birth certificate data, so theoretically we have every birth in our state or locale, whatever. But anything we do with data, even when we have big data, needs to be thought of as sample data. And what that means is, even if no, you know, like with birth certificate data, we haven't taken a sample of anything. It's not like using data from a sample survey. No formal sampling has occurred. but those kind of rules of sampling are still in play. So what it says is that we never really know the truth. Even an estimate from a birth certificate may not be true. There's going to be some kind of error in anything we report, and so part of our job is accounting for that uncertainty and error in our data. And that's really at the heart of statistical analysis. For the classic way of thinking about epidemiology, again, often you see these two broad categories. Descriptive epidemiology, which is about summarizing the distribution of risk markers, risk factors, or other indicators, outcomes, without stating any kind of hypothesis, not formally stating a hypothesis. And then analytic epidemiology moves us towards, again, testing formal hypotheses. So, you know, about those estimates, and it could be hypotheses about classically exposure outcome relationships, or in our world, it does move beyond that to testing hypotheses about health services or policies, and including the social determinants of health. And in the person, place, and time classic formulation for epidemiology that we all learned, that at least always has meant that we were thinking about the fact that health and disease aren't just located in individuals and aren't just biologic phenomenon, but they're byproducts of the intersection between individuals and the context in which they live, work, and play. So, you know, epi kind of has always inched towards the consequentialist approach more than many other basic sciences, but you know, we have a ways to go. The problem, at least as I see it with those two, whether we talk about estimation and hypothesis testing or descriptive epidemiology versus analytic epidemiology, I find that classic language sometimes gets in our way. And the example I've given here is because I know this is true for me, and I'm guessing it's true for all of us, that we almost feel defensive, like we say, oh, well, we're just doing a descriptive analysis, you know, as though that's somehow either less rigorous or less rich or not as informative, you know, too simple. But really, I think we have to change the way we use this language, because honestly, descriptive epidemiology is not synonymous with just using simple and simplistic methods. It can be incredibly complicated, and it can include multivariable methods. And conversely, analytic epidemiology is not synonymous with just, it's not the same thing as multivariable methods. So in analytic epidemiology, we will undoubtedly use multivariable methods, but it's not the same thing. And I think we often confuse this jargon, and I'm sure we will talk about this more this week, because I think we're all, you know, we tend to use words and we tend to use them in the way we've learned them, and I think it's good for us to work on making sure that we mean what we say when we use some of this terminology. So as we move to doing real analysis planning and getting that systematic plan in place, I've just listed here, you know, what we do at the very beginning, and always connected to what our agency's priorities are. So we are going to anchor ourselves by some theory and by the existing literature and by existing practice. We're going to want to articulate the questions we want to answer, either addressing what we see as gaps in knowledge, or maybe there's not so much gaps in knowledge, but we're going to ask questions that pertain to thinking about prevention and intervention strategies. So it's going beyond the expanding our knowledge about, let's say, exposures and outcomes. But then what do we do next? How are we going to address? That's our role as public health professionals. We're going to identify relevant data sources, think about, do we need new data? Are there linkages available? Can we accomplish linkages even if they're not currently available? We're going to develop a conceptual model that addresses the question we've articulated. And then we're going to do an actual analytic plan that includes what methods are we going to use, how we're going to carry out the actual analysis. So to stop for a minute and think about asking the questions, and the questions really depend on what our the particular project we're working on. So it could be something as simple, and again, I'm not using that word pejoratively, but something as maybe straightforward. I don't know. See, what's a good word? It's important. Maybe what's just the incidence or prevalence of a given indicator. And then we might go beyond that by saying, does the incidence prevalence of an indicator vary over time or by geographic location? And then we might move out of just thinking about incidence and prevalence and say, how severe is the health problem we're addressing, and link it to how intensive are the interventions to address it. So link it to the health services that exist. Then we might think about trend data. What's the trend in health status or in an outcome relative to the trend in services provided? So again, maybe we could also just, of course, initially just say, what's the trend in an indicator we're interested in? But then move beyond that and maybe link that to the services designed to address it. And then get even more macro and say, are health systems promoting or inhibiting access to health services? So moving out, again, from thinking of sort of the individual or collections of individuals, population groups, to thinking also about services intended to serve them, policies in place to address issues, and systems functioning and the way systems are organized. And then, of course, the last bullet point is the more classic, traditional epidemiologic analysis. What's an association between a risk factor and an outcome? So we better know where we are before we start deciding, oh, I want to do this kind of method or that kind of method. And also, before we actually dive into analysis, we actually think it's important that you kind of work backwards. And I assume they still do this, but I have to admit, I first learned this idea when I was forced to do it by the PRAMS program at the CDC. This was probably like, 25 years ago or something. And I was writing a proposal to use PRAMS data, and they insisted that as part of the proposal, which the proposal itself was not, it wasn't like, writing an NIH proposal or something, but I had to give them table shells, or I had to give them some, potential graphs or figures that I was thinking of using. I had to think about what my final products were, and maybe even articulate potential narratives. So it's before analysis. I don't have my results yet, but I can still write out, given what we see in our, given what we found, this is what we think from a programmatic point of view, or this is what the data show, our findings show from a policy point of view, and start thinking through the endpoints. Again, hasn't this happened to you that you do what you might think is a great analysis, and if you haven't done this and you start putting together the report and all of a sudden you realize, I'm going to have to go back and rerun a whole lot of things because I really don't have things organized the way I need. So in the interest of, analysis is always iterative. We all know that. But to really try and focus ourselves and not, have quite as many iterations, this is really helpful to force ourselves to think through what our presentation is going to look like. So we've got theoretical frameworks, we've got prior analyses and what's in the literature, we've got the experience of practitioners, and we've also got the understanding of political will and in a obviously practical sense, what's feasible, what's the possibility for funding, and all of those together really guide our thinking about what we're going to analyze and what we're going to report. So when we get down to we have our analysis plan for the most part, then we can start doing things also, even as part of the planning process, but certainly as we move into data analysis. What are our variables, and are we going to make some maybe composite variables? If we're working with sample survey data, how are we going to handle skip patterns? If we're going to use complex constructs, are we going to use certain things like the APNCU, or commonly called the Kotelchuk index, which combines 3 different variables? Same idea really with lots of variables, smoking patterns, but I work a lot, and I may talk some later this week about looking at adverse childhood experiences. Well, there, you've got a series of 8 constructs. What's the best way of, again, summarizing the data that's going to be informative? Looking at SUID data. We've got multiple risk factors. How do we want to handle them? Do we want to handle them separately or jointly? And if jointly, what are we going to do? Same thing with every kind of measure that we have. So again, it's important to at least start thinking about these kinds of issues before we dive into the data. Other ways that we might organize variables and even think this through at the planning stage is to group variables by domain. I often like to do this because, again, we often have a rich set of data, and it's going to be hard to handle 20 or 30 variables jointly or however many. So to reduce the data burden, think about ways we might group variables, and even if it's not creating indices or but grouping them somehow as we move through analysis, so that we might want to look within each domain separately at an initial stage of analysis before trying to do some cross-domain analysis. And these are just the obvious usual suspects for domains, but you can think about domains in lots of different ways. And you also might want to group variables based on what's already in the literature and what other people have done that seems to have been a meaningful approach, even if you're going to go on and do something a little bit different than others have done, but to get as much consistency and build upon the literature in ways that are important. It's always important to anchor to what's been done before. Another way to group variables is to think about the notion of modifiability or unmodifiability. So what factors, again, when we really want to focus on public health action, ultimately, what are we going to do to address public health issues for infants, women, children, and families? Maybe group variables into those that we think really are changeable or modifiable, and those that aren't. And the way we'll handle each of those different categories of variables will be different in analysis. So it helps us from the get-go understand, okay, these variables I'm going to handle as modifiable factors, and these other variables I'm going to consider unmodifiable. And of course, all of these, including these categories, there are gray areas. It's not always so obvious whether a factor is modifiable or not, and but then it's a good point for discussion with our stakeholders about, can we change this? How can we handle this variables. The summarization process then involves all those steps and ultimately thinking through on a continuum for a particular analysis that we're doing, what's the balance between specificity and interpretability. So, you know, in some ways, we like to do really rich, refined, unsummarized analysis, you know, get down to small, very small population groups or very small geographic areas or you know, very just unsummarized data. And then the other end of the continuum, of course, is much easier to interpret, but that doesn't mean it's always better. So we could get, you know, to the other end of the continuum and only report, you know, the overall impact of an indicator, not stratified by anything, and it will be very sort of interpretable, but also maybe misleading. So where is the best balance on this continuum as you think through the analysis you're going to do? Some examples of this too. So thinking about, we have some rate on an indicator. We have lots of choices of how to report it. I've just listed a few here, you know, by all of, by age, race, ethnicity, county, and year, maybe age, race, ethnicity, and county, but we're not going to do trend data at this point in time. Maybe just age and race, maybe just by age, maybe not at all, maybe by something else. What is our goal for the analysis and what choice makes sense? And then also we have to think about what data are available. So we might have a great ideal analysis plan and then realize we don't really have the data we need. And here I've used the example of the incidence of childhood injury by type of injury and age, but often we don't really have real incidence data, right? We most likely have hospitalization data, and even more narrowly, we easily have mortality data. But, you know, so what does that mean for what we really want to say about childhood injury? And how does that drive the analysis that we'll do? Just a few final notes, because I did say this before, and I'm really throwing this out there for, let's all talk about this as we move through the course next week. You know, we do live in a multivariable, multifactorial world, and so you can see kind of what my bias is. I like knowing about and using multivariable approaches when they're appropriate and when I see a reason for using them. So I think there's been sort of a more recent, especially in public health agencies, of saying, well, no, you know, that's just for researchers. We shouldn't do any of that. I just want us to find some balance, and I think we will, because you're going to get a lot of instruction in high-level multivariable approaches next week. So when does it make sense? What's the balance in our world, in MCH epi, in applied epi? When do we want to be using multivariable approaches? So I've just, you know, listed here a few ideas. So, you know, in observational studies, you know, we might again want to be looking at modifiable systems factors and linking them to health services linking those health services to health status outcomes. In intervention studies, you know, so you're going to learn a lot from Dr. Ocampo about high-level program evaluation, and so there, often multivariable approaches are useful. You know, when there's not already a sufficient understanding in the literature, then obviously there's room for people doing more typical risk factor outcome studies. Even when there is empirical evidence in the literature about a relationship, but you think it might be different where you are, or you think there might be some new, although the evidence is there, but could we refine the evidence by using some innovative method, not purely replicating what's already out there, but expanding on that and maybe giving us a richer look and more clues about better prevention or intervention strategies. And sometimes descriptive analysis, multivariable methods, again, is not synonymous. It doesn't necessarily mean doing regression modeling. It might be doing something like cluster analysis, which isn't doing exposure outcome relationship. It's a multivariable approach to helping us, again, summarize data. So I leave this with you for us all to think about, and let's talk about this more. At what stage of analysis might we want to use these methods, even when we might use them internally for ourselves at some initial or intermediate stage to help us think more critically about what we're doing, even if our final product is not going to be based on those multivariable approaches. That's my soapbox talk for the day. So as we step through our analysis, this is in general part of that iterative process, and I know you've all seen this. I mean, you've probably done this 1,000 times, but to remind ourselves about, selecting the variables, defining categories if it's appropriate, looking at univariate and bivariate distributions, doing single-factor stratified analysis, and then maybe going backwards again and rethinking variables and categories. Then maybe moving to multiple-factor stratified analysis, which really is multivariable, but it's still at the contingency table level, and then maybe doing multivariable approaches. And again, it's very, very fun sometimes to skip to this approach and this approach, and it's just important to start somewhere near the beginning to end up where you want. Let's look briefly, and these really are notes about theory, because I will admit to you that I myself didn't get the best grounding in theory. And, I have a much more kind of empirical, methodological perspective on doing good data analysis. So again, I'm challenging myself here. But I wanted to share this with you. So, theory is critical due to epidemiology's intrinsic interest, this is from Nancy Krieger, in elucidating causal explanations of disease rates in populations. And then theory helps us structure our ideas, this I totally agree with, so as to explain causal connections between specified phenomenon within and across specified domains by using interrelated sets of ideas whose plausibility can be tested by human action and thought, okay? And then I've just said, well, hold on a second. Way back when we started with consequential epidemiology, didn't we say that at least in our world, in kind of the world of public health work, because we're not doing research epidemiology for the most part, didn't we say that causation isn't our primary focus? So what is the role of theory? And this is where I guess I land on it, that even if we're not going to make formal hypotheses, et cetera, that theory still, again, it's a way to force us to systematically think about how we're generating our analytic questions and generating our analysis plans. The next few slides are just showing you a few, the kinds of theories that are out there, and I assume many of you have seen various versions of these, and again with Dr. Ocampo for sure, I think you'll be talking about logic models, which in a way is sort of similar to these theoretical and these conceptual models. So this is a theory of planned behavior. Here's the EcoSocial Framework, and again, you can see here, starting at the individual level and building outward and, all the way to the top to the policy level, but, specifying the directionality of how these things, how each of these domains are interrelated. Here's another version of an ecologic framework. Similar idea. In here, we're starting in the middle at the individual and then moving out and out and out and thinking about all the way out here, way out. And again, to me, this is all just confirming that we live in a multivariable, multifactorial, multi-layered world, and what is the best approach for us accounting for that in our work and in our analysis. So LifeCourse Perspective, which of course in MCH, this is really we're focusing on this a lot. So there's a lot of consensus, that health is not produced cross-sectionally, but throughout life, and that what happens in all the way from conception out through the perinatal and postnatal influences in childhood, all will contribute to adult health, and that early life exposures from a critical period will really matter. And this is one version thinking about a life course approach to cancer later in life. And you've got all the sources here if you want to read full articles. And just another, the Anderson model, which is from 1995 of healthcare utilization. What gets people, who uses, why do they use, what are the influences on that use? And more. This is anyway. I think you see where we're going with this, and I think you are going to be asked to maybe at least draw some logic models, which are not these big macro picture, but in terms of like how programs work, it's a very similar process of thinking through how things are going to work. And this is also about when we get out to the systems level, thinking about systems, so including all the resources that are available to address a problem, where services are located, so in addition to personal resources, what are the societal level resources, etc. The next few slides, and because I even see, we're almost running out of time. In the past, so I think all of you know that we consider you intermediate or advanced. So that's, epidemiologists. And so that's why next week we're really going to do a lot of diving into some sophisticated methods. But, people have been out of school for a long time, or depending on what your work has been asking of you to do, I'm providing you with some really summary cheat sheets about what it is we're talking about here, what we mean when we talk about measures of occurrence in our world, what we mean when we talking about measures of association, and that there are difference measures as well as ratio measures. You're definitely going to hear more of that from Dr. Harai. A little bit about the relationship between those kinds of measures and probability, the probability distributions that they theoretically follow. Confidence intervals and what it means to have a confidence interval around a measure of occurrence, which is this guy. So around an estimate, and then here around a measure of association. and again, the relationship to some probability distribution and to a standard error. So probability distribution and a standard error. And then really summary, kind of the basic components of any analysis. What statistic are we going to report, and what is the population parameter that we think it's estimating? What sample size do we have? What are the standard errors or the variances of that sample statistic? What are the probability distributions that we're referencing? So I know, this is like what, 4 slides. So I just want to say to you that next week, even if you consider yourself, and we consider you, people that have a lot of grounding and expertise already in basic stats and epi, I am available at any time if anybody wants to go over whether it's, contingency table analysis or anything about defining variables or what different levels of measurement are and what the implications are for which kind of methods apply, anything like that. I hope you're not going to feel, shy or whatever about asking that, because everybody needs a refresher on this stuff if we don't use it. So please, 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 that's an invitation to let's talk about any and all of that next week. And just my final soapbox, which is, again, let's have more discussion about simple versus complex and where we want to land as we're designing and implementing analytic and presentation approaches so that we can really promote public health action, which is what our jobs are really all about anyway. And that's it.
Thanks, Deb. You're right on time.
Because nobody interrupted me, which I'm also hoping on site people are going to be more willing to interrupt.
I would hope so, and I encourage all of you participants or scholars who are on the call to please do be interactive on site and feel free to ask questions. So you're going to be getting your before you go email this afternoon, and along with some other information this afternoon, and we will see you on site next Monday. Thank you so much, Deb. And finally, anybody, if you have questions, call or email me. Have a great day, everybody. Thank you.
Thanks a lot, everybody. See you next week.